Respiratory problems are common in infants and children and can rapidly progress to respiratory distress or failure. Respiratory symptoms account for 10 to 20% of pediatric emergency department visits. Early recognition and treatment of respiratory compromise are critical for improving the likelihood of a positive outcome. Basic airway management can be a life-saving procedure in pediatric patients. The first step in the assessment of critically ill or injured children is an evaluation of the patency of the airway and the adequacy of ventilation. For spontaneously breathing patients with a clear airway, resuscitative efforts may focus on oxygenation. This maneuver is contraindicated in a patient with a potentially unstable cervical spine injury. Stand at the head of the bed. Use your non-dominant hand to apply downward pressure to the patient's forehead to gently tilt the head back. Using your dominant hand, position the tips of your index and middle fingers on the mentum of the mandible. Gently lift the mandible by pulling up and toward yourself. If this does not relieve the obstruction, place the thumb on the lower lip and press down, or place the thumb behind the lower incisors and pull the lower jaw forward so that it is anterior to the upper jaw. When properly performed, this maneuver opens the airway with limited movement of the neck and is therefore the procedure to be used if there is concern about possible cervical spine injury. Stand at the head of the bed. Place the heels of your hands on the temporal parietal areas on each side of the patient's head. Grasp the angles of the mandible with your index and long fingers and displace the lower jaw anterior to the upper jaw. An OPA should only be used if the patient is unconscious or minimally responsive, as an OPA may stimulate gagging, which poses a risk of aspiration. Choose an OPA of the appropriate size. To determine the appropriate size, hold the oral airway beside the patient's mandible, orienting it with the flange at the patient's mouth and the tip directed toward the angle of the mandible. The tip of an appropriately sized OPA should just reach the angle of the patient's mandible. Position yourself at the head or side of the bed near the patient's head. Open the mouth either by using the thumb of your non-dominant hand to apply downward pressure on the chin, or by inserting your thumb and index finger into the patient's mouth to open the mouth. Use a scissor technique, performed by exerting gentle downward pressure on the lower teeth with the thumb and upward pressure on the upper teeth with the index finger. Additionally, you may use a tongue depressor to help displace the tongue for ease of placement. The OPA may be placed either straight with the curve position down or at a right angle to this position. For placement using the curve down position, gently slide the OPA down the tongue until it sits comfortably in the oropharynx with the flange resting at the lips. For placement using the OPA in the right angle position, insert the OPA in the mouth and then gently turn the OPA so that the curve is facing downward and it rides along the tongue until in position with the flange at the lips. Confirm airway patency by assessing for chest rise, breath sounds, and oxygen saturation. If ventilation remains inadequate after OPA insertion, the OPA size or position may be suboptimal. Remove the OPA and verify that the size is correct before reinserting it or choosing a different size. Often, a larger OPA will succeed when a smaller one fails. Choose an NPA of the appropriate size. Size is most accurately determined by length. An NPA of the appropriate size extends from the tip of the nose to the tragus of the ear. Alternatively, an NPA can be sized based on diameter. The diameter should be slightly smaller than the internal diameter of the nair. Position yourself at the head or side of the bed near the patient's head. Lubricate the insertion end of the NPA with water-soluble lubricant. Select the nair that seems the most patent. Insert the NPA along the floor of the nasal cavity with the bevel facing toward the septum. Advance at a caudal angle that is approximately 15 degrees. Continue until the flange rests against the outside of the nair and the distal tubing extends behind the tongue into the posterior pharynx. Confirm airway patency by assessing for chest rise, breath sounds, and oxygen saturation. In young children, devices placed directly on the nose and face may cause increased agitation and hinder oxygen delivery. In such cases, it may be wise to start oxygen delivery with a passive system, such as hollow plastic tubing with a flow of oxygen passing over the child's nares and mouth. Here we see blow-by oxygen connected to a continuous oxygen source in line with a humidification device. Simple corrugated tubing can be used to deliver oxygen in this passive manner. A continuous oxygen source is dialed until a visible mist is emitted from the tubing. This often requires anywhere from 10 to 15 liters of flow when attached to a humidification source. Oxygen is then passively delivered over the nares and mouth of the young infant. A nasal cannula is able to deliver a low flow of oxygen through two small prongs placed underneath the nares of the child, with the other end of the tubing connected to a continuous oxygen source. Here we see continuous humidification, which is given for any patient receiving continuous oxygen via nasal cannula to prevent drying of the nares. Nasal cannula prongs are carefully placed underneath the nares, and tubing is secured around the ears and fitted with an adjustable strap. A nasal cannula is best tolerated and effective at flows less than or equal to 3 liters per minute. The nasal cannula can easily slip from underneath the nares, and oxygen can easily be lost to the environment, so this delivery method is not ideal for patients requiring a higher concentration of oxygen delivery or for an uncooperative child. All patients receiving oxygen should be monitored with continuous pulse oximetry. Levels at which to start oxygen depend on the underlying pathology. Oxygen should be started for any patient in respiratory distress. Simple face masks can deliver higher and more reliable concentrations of oxygen than a nasal cannula or blow-by oxygen. Oxygen delivered by simple face mask should be connected to a continuous humidification source to prevent drying of the nares and secretions. You are seeing a humidification connection specific to our institution's face mask. Please be familiar with setups that may be different in your area of practice. The simple face mask is connected to a continuous oxygen source with humidification via corrugated tubing at this institution. The mask should be fitted around the skull with the use of adjustable straps to find the best fit. The mask can be fitted on the nasal bridge by gently pinching the adjustable metal band. A properly sized and fitted mask should cover the nares and mouth without covering the eyes or hanging below the chin or jawline. It is important to note that a minimum flow rate of 6 liters per minute is needed when using simple face masks to prevent rebreathing of exhaled carbon dioxide. At a rate between 6 and 10 liters per minute, and with an appropriate fit, a face mask can deliver an estimated oxygen concentration between 35 and 60%. Simple face masks have exhalation ports, which also entrain room air, and thus will lower the final concentration of oxygen delivered to the patient. Continuous pulse oximetry monitoring should always be used for patients receiving supplemental oxygen. A partial non-rebreathing mask is able to deliver higher effective oxygen concentrations than a simple face mask. A partial non-rebreathing mask has a reservoir bag and one-way valve to reduce rebreathing of exhaled carbon dioxide and deliver a more oxygen-rich source during breathing. Always make sure that a non-rebreather mask is connected to a continuous oxygen source. A non-rebreather face mask is fitted in the same manner as a simple face mask. Fit strap around the skull and use adjustable straps to fit the mask around the nares and mouth without obstructing the eyes or having the mask hang over the chin or jawline. Flow should also be a minimum of 10 to 12 liters per minute to properly fill the reservoir bag and to prevent collapse of the bag during inspiration. Entrainment of room air still occurs through exhalation ports, and a concentration of 50 to 60% oxygen can be achieved with a flow of 10 to 12 liters per minute. To deliver higher oxygen concentrations, a partial non-rebreather can be converted to a full non-rebreather. A full non-rebreathing mask looks much like a partial non-rebreather, but has an extra one-way rubber seal over one exhalation port to prevent entrance of room air and to allow proper exit of exhaled gases. For safety reasons, only one exhalation port should be covered at any time. If both are covered at the same time and the reservoir bag becomes disconnected from an oxygen source, the patient will not be able to breathe room air and will have no oxygen to inhale. A non-rebreather is always hooked up to a continuous oxygen source. Flow should also be a minimum of 10 to 12 liters per minute to properly fill the reservoir bag and prevent collapse of the bag during inspiration. A non-rebreather face mask is fitted in the same manner as a simple face mask. Fit the strap around the skull and use adjustable straps to fit the mask around the nares and mouth without obstructing the eyes or having the mask hang over the chin or jawline. The reservoir bag should be inflated and not collapse when the patient inspires. When fitted and connected properly, full non-rebreather masks can deliver oxygen concentrations of greater than 95%.